Immunotherapy. So I would argue that over the last 40 to 50 years, as our understanding of immunology and human immunology improved, our understanding of why we have innate immunity, why we have types of immune cells that block infections, as we have learned about how different cells create antibodies to fight disease, people have jumped onto that bandwagon to start to understand how or why immunotherapy could actually be leveraged to fight cancer. And so it's really an interesting thought, the idea of spurring our own immune systems to recognize disease, I think, and to recognize cancer specifically, is a very important point to think about. Because ultimately, many disease processes are a product of a lack of balance in immune and inflammatory regulation in our body. So at the end of the day, our bodies are exquisitely sensitive to change, and it would be foolhardy for us to think that our bodies did not develop regulation of processes and counter-regulation. And so I'm going to give you some examples of diseases where the immune system has been, to be really simplistic, messed up in order to facilitate a disease process. And I'm going to also tell you how overexertion of our immune systems can cause problems as well. So the disease, like diabetes, cancer, obesity, COPD, emphysema, rheumatologic illnesses, heart failure, neurologic illnesses, dementia, they all have a component of an inflammatory or immune dysregulation. If things were regulated, you would not see the extremes that we see in different populations of patients. And so balance, in the end of the day, for whether you're an oncologist or a cardiologist or a rheumatologist or a urologist, balance is the key to optimizing patient management and patient health. And so what is the other extreme? What are scenarios where our immune systems are overactive and almost too good to be true? Lupus, multiple rheumatologic disorders like scleroderma, thyroid conditions. A lot of those conditions are not caused by a reduced inflammatory situation or immune situation, but by a heightened immune situation. So all along, biologists started to realize maybe there's something to regulating our immune systems in order to fight cancer better. And so I would say that people have been looking into this for 50 years or so. And then in the 1980s, a physician named James Allison, who's now at MD Anderson, discovered a molecule that tumors use, in fact, to suppress the body's immune system. And by suppressing the body's immune system, these tumor cells can flourish. So he did these studies initially in animal models, in mice. And he showed that if he took an antibody and directed it against that mechanism, directed it against that molecule that tumors used to dampen our immune system, what he actually saw was an enhancement of our immune system's ability to fight that tumor. And that was what we would argue would be the first immunologic checkpoint inhibitor, our proof of principle that inhibitor worked. So that was discovered in the early, late 1980s, and then it took 92, I got to count this in my head, but it took about 20 plus years of looking at it in phase 1 clinical trials, looking at it in phase 2 clinical trials, looking at it in phase 3 clinical trials, before it actually became standard of care as a treatment for specific types of cancers. And so that, in a nutshell, is kind of the general overall explanation for how we went about trying to understand how to optimize our immune systems. Now, it has gone beyond using an antibody to fight or to block an interaction between the tumor and the immune system. Now, different groups can, for instance, take your cancer cells, make them more immunogenic outside of your body, meaning in the tissue culture situation, they can take them, they can do things to those cells, they can engineer those cells to be more accessible to our immune systems. Then they can return it back into our bodies to support kind of like a vaccine approach, and the immune systems are better able to recognize those tumor cells as being bad and then can try to eradicate or eliminate them. One of the ways they can do that is to introduce viruses that our immune systems definitely can recognize. Introduce a virus or protein particles from a virus into the tumor cells, into some of the tumor cells, put them back into your body. Once those tumor cells start expressing those proteins, then the antibodies that recognize that virus will start eradicating not just those tumor cells, but all tumor cells that are similar to it. So we have come very far in oncology in general, and definitely in urologic oncology. This is one of the golden eras of medical and cancer management. And it is because, in part, that we have developed very accurate and effective immunotherapies to combat different types of cancers. And so now let's, with that background, we'll start going through some of these slides. So what you can see right here, let me see if I can use the arrow. Okay, what you can see right here is a combination, the schematic is a combination of a tumor cell and an immune cell. And historically, as I pointed out, Dr. Allison was able to identify proteins on the surface of the tumor cell that blocked the effectiveness of these immune cells. And by identifying the molecules that blocked the effectiveness of the immune cells, what he could do is introduce into the animals originally, and then eventually into humans, antibodies that go and attack, not MHC, but go and attack these classes of tumor-specific proteins. The antibodies directed against these tumor-specific proteins, such as ipilimumab, atezolizumab, pembrolizumab, and nivolumab, fight different aspects of this interaction. And by using those antibodies to block the interaction, the immune cells were no longer restricted, they were no longer suppressed, they were no longer checked in place. And so then they could recognize the tumor cell as being something that they need to attack, something that is not normal, I think is the best way of putting it. And so for this identification of this molecule and this interaction, he won the Nobel Prize, I think about 2 years ago or 3 years ago, and it has revolutionized the utilization of immunotherapy for all types of cancers. And so it was really one of, we're in the, as I said, in the era of one of the most rapidly developing periods for oncologic management. Not just improving patient lives and quality of life by a month or two, but we're talking about by years. And so this is why has such been a paradigm shifting event. But as I pointed out, it's taken decades to evolve. And so at the end of the day, we need to develop when we think about cancer care and cancer management and optimization of management, we need to think about a therapeutic balance. And what do I mean by a therapeutic balance? And so historically, for advanced disease, and when I mean advanced disease, I mean stage 4 cancer.